Lovely to see so many of you, some of whom I've seen in the classroom and some of whom I haven't, but welcome. John and I have really structured this hour and a half in the following way. Firstly, to give you some thoughts on the challenges of getting change to happen in a complex environment like healthcare. And then we're going to very much put you into breakout rooms and have a kind of networking discussion on a couple of questions and try and make this as interactive as we can in this media. So let me start by hopefully sharing my screen. Hopefully that will work now. And just set up this. I have spent rather longer than I care to remember actually sort of studying healthcare change over many years, and also have become, because of my work in the business school in executive education in particular, interested in the topic of leadership. And one of the things that I have noticed over some 30 years of studying healthcare settings is the importance of leadership in getting things done, or the importance of leadership causing things not to go as well as they might. So I want to share with you a very brief case study, and it really is brief, to demonstrate really why it's tough leading in healthcare settings, and then begin to just make some reflections about how we feel the nature of leadership work needs to change if we're really going to make progress. So that really is the agenda of the 20 minutes or so that we've got together. So if I may, then I'll start this particular example, just because I think it's always helpful to start with an empirical example. And this is a story many years ago now of a UK attempt to get genetic science, so brilliant scientists working in the area of genetics, doing brilliant work, to engage more closely with the NHS, the National Health Service, who were very keen on translating this knowledge into services to make a real big difference to patient care. So this was a change where both parties, both settings, the university, the knowledge brokers, if you like, and the NHS, the delivery mechanism, really wanted to work together to make this happen. So there was no discussion or no difference in reasons why they wouldn't work together. So this looked a promising site for work. Now, if you begin to explore that, as I have done with many of the research projects I've been involved in, you start by interviewing the policymakers, the people who actually put this idea together. So in this particular case, we have this desire by UK government to get genetic science more into healthcare worlds. And thinking about that, they thought about this idea of creating 5 or 6 centres of excellence throughout the country, where they could become sort of playgrounds or experimental grounds for doing this kind of change. And we studied, a team that I was leading studied one of these. And what was interesting is that they went down this idea about a genetic park, a little pathway, if you like, where people would come together and work together on this legitimate aim of getting knowledge into practice. And I interviewed the chief civil servants in this space, and got this kind of quote: "The idea for these genetic knowledge parks appeared very late in the drafting of an NHS plan, virtually just a sentence, just a throwaway sentence that took everybody by surprise. And when the then health secretary was questioned what it was, he said, 'You tell me,' and then we developed some themes." Now, this could be this kind of quote. Could be in many of the research projects that John and I have been involved in, where essentially somebody has a bright idea, and rather than think it through in a kind of project way, or what were the themes, what were the challenges, you often get this kind of change idea thrown out into the system. And then people develop themes. And clearly what you've got there is a very unclear specification of what these kind of playgrounds or environments should do, irrespective of this desire to get genetics into practice. And again, I want to emphasize that in healthcare contexts, when you're trying to involve change or trying to make change happen in the way I'm describing, gosh, there are an awful lot of people and groups involved. And one of the things that I think leaders need to do increasingly, no matter what your context is to begin to map the complexity of the stakeholders or groups that are involved. And you can see in this particular example, you've got the Department of Health, who I think I've already said were slightly unclear about what this was all about. You have the Department of Trade and Industry, who got involved because they got some spare cash and basically wanted to get this entrepreneurship theme going as part of this kind of change process. And you see the university and the hospital, you see research involved. And typically, and this is quite a feature now, I think as John will also echo, it's quite a feature now to try and get multidisciplinary work going in these change projects. So you have scientists, medicine, social science and management and policy, all of whom have very different upbringings, a very different educational paths coming into this context. And this is really what the leadership team involved here had to manage. Look at the complexity of the different interest groups. And if you begin to push that a little bit further, you begin to see these communities of interest. And it's really important, I found, in change work to be curious about the different interest groups that are involved in the change process. So in this particular example, you have medical scientists who have university careers. So they have to publish, it's this publish and perish. They're on a trajectory where their careers and their incentives are firmly lodged in publications and getting research grants. And of course they are typically, they've had a medicine, undergraduate, postgraduate upbringing. And then you have NHS medical scientists who share the upbringing, share the medical upbringing, but have a set of incentives which are focused much more around the hospital, patients, patient care, services responsibilities. You also have in this story research scientists who are biomedically trained and NHS scientists who are biomedically trained. But again, the incentives where they work, who pays their wages, who constructs their careers, makes a difference to where their interests are. And then we have social scientists from the university, different background, interested in a perhaps more curious about ambiguity, more interested in qualitative work rather than quantitative work, etc. And then you have the policy community. And clearly this particular example was in a business context, in a commissioning context. So, money was important, budgets were important, commissioning the services into practice and who bears the cost of that were important. Now, I go into some detail about that because it is a feature of many of the contexts that we've been involved in, John and I, where this matters. It matters what these groups care about. What does this change mean for me? And the story in a nutshell, and we studied this over, I think it was about 7 years. So I went to far more medical meetings than I care to go to, but and things move very slowly in science, and then they kind of rush at the end. But actually the story is here of a whole series of conflicts, very sadly. And people generally found it very difficult to work together, not because they didn't agree about the change process, but simply these incentives and these career incentives and language and the ability to speak the same language got in the way. And just to give you a sort of sense of what some of those clashes might mean, you remember I mentioned that there were two types of research laboratory colleagues. One worked in the university and one worked in the NHS labs, where you have to do really careful work so they don't get testing wrong. And you can see here a flavour of some of the clashes. The way we work in the research lab is we try and get everything as fast as possible because it's a competitive world. We need to scrape over the surface for the big prize. Whereas the clinical genetics lab, thank goodness, is incredibly compulsive and obsessive because they don't want to get our results wrong. They do everything in duplicate and never get it wrong. It just takes too long for my agenda of getting these papers out. They, the NHS scientists, feel they're providing a service and being careful, and we, the research scientists, are feckless people who wander in at 11 and go home at 3 and look for glory. And so you get this competition where knowledge sharing, even within teams who speak the same language, become difficult. And then perhaps more starkly, I mentioned that social science typically are coming into work very sensibly with colleagues from medicine and science. And what was interesting about the social science experience was the economist colleague was able to communicate with the scientists because they had the language of numbers, and that was a kind of good relationship. Whereas, this wasn't me, by the way, but it could have been, the sociologist's work was weird and of no benefits. Our world is very black and white. So when a sociologist talks to me about barriers and networks, it doesn't mean much to me. These weird sort of sociology people, we're providing material for them to write interesting papers, and so it goes on. So the reason why I share those, because this agenda here was not just a failure of leadership in a project change way. It was, in a sense, an example of the kind of complicated problems that actually we don't just face in healthcare, we face in many organizational settings where the nature of the leadership work simply has to change, or we're going to get this kind of misunderstanding. And of course, in this scenario, what was interesting was it wasn't until the end that the commissioning, the people who actually were funding the tests that were eventually developed were involved. They were not involved until right at the end. Such was the excitement about the science. So where does that take us then? I think what I use that example to suggest is that, as you all know, change is complicated, very complicated. And the curiosity that we as leaders need to really nurture in ourselves is not just about the context, but it's about the groups within and the people within the context and how they see the change world that you're trying to navigate. And I think the other thing I would say is that we need, as leaders, in whatever context now, but particularly I think within healthcare context, we need to recognize that actually there needs to be a different way that we need to look at organizations. Organizations have often been looked at as things and processes where individuals make choice and take actions, where you've got wise, decisive, heroic leaders. It's rational. Results come from choices and intentions. And Ralph Stacey, who is a really wonderful social scientist on this, argues, but actually, if you're really honest about how you experience organizations, you experience organizations as conversations. We're interdependent, as you could see from that example. We're interdependent, we're entangled, we're also emotionally entangled. And that interdependence constrains and enables. No one can control it. I do a lot of work with leaders, interviewing them, and leaders talk about being accountable but not in control. And I think that has probably always been true. It's probably noticeable now. No one can control what everybody else is choosing and doing. And far from this rationality, at the end of it, people are emotional. They care about their work. We all have different personalities, etc. And what we experience increasingly is uncertainty. And leadership increasingly is about holding that uncertainty and exploring it before we rush to action. Pausing is not stopping. And these local contingencies become even more important to understand. So we have, as leaders, I would argue, to move away from the dominant narrative, to be a little bit more on the right-hand side and recognize that there will always be unintended consequences of change, simply because this is how organizations typically work. And so while there is a lot of discussion about what's the difference between leadership and management, and that is an interesting debate, we're going to argue that leadership today, and it, obviously after what we've gone through in the last 14 months or so, increasingly is about ambiguity, uncertainty, relationships, feelings, people, chaos. So if you on this call feel as though you are walking in your work life on swampy land, then you are actually probably doing fantastically important leadership work. So just to make that point, that I think that is the way in which we have to start thinking about that. And that involves really being very comfortable about this notion of moving from classical leadership to trying to build an environment where leadership is not with one individual, or even a group of individuals. It is shared. And that we will be evaluated as leaders, not by our individual efforts, but how well people are working together. And of course, that model of leadership involves, I think, a new set of skills, which I'd like to say a little bit more about as well. And those of you that have had the, have been involved in the Diploma in Organisational Leadership or the AMBA will have seen this slide if you've taken Leadership Fundamentals. But I make no apology, because I think it's an incredibly important slide in relation to leading change. And that is that leadership work is not about one thing. The problems that you face as a leader often fall, and I'm simplifying really terribly, but often fall in three buckets. One is where you as an individual are faced, or as an organisation rather, are faced with a critical problem where the answer is pretty obvious. And at that point, you use your power as a leader, you use your position, and you say, this is how we're going to do it. So in that moment, the work is to provide the answer and to provide clarity, because the problem is relatively easy for everybody to see. So the example, when we had to close the business school down 14 months ago, whenever it was, that was the time for decisive action. And everybody could see what needed to happen. Actually, I rather enjoyed that period, because, it was kind of nice telling people what to do, not just me, but a group of us, and people did it. So I rather enjoyed that. But anyway, that was the work. Sometimes you're faced with leadership work where there's a puzzle, there's a problem, but it can be tamed. And in that moment, your leadership work is to go out and find a colleague who's solved the problem, or go to another organization, and you are basically going to learn and then to bring that knowledge back to apply locally. And there you're using what I would call more classic management, project management type of techniques, transformational type work of change management that is fairly sort of rational and standard. But sometimes, you're faced with these really challenging problems, like how do you get genetics into NHS practice, which, and this slide we called wicked problems, but they could be adaptive problems, complex problems, it doesn't really matter, but they're different problems. And these kind of problems require you as a leader to do influencing work, to use your soft power, to ask questions, to have a different set of leadership practices that are going to help you make progress, convene conversations with people who wouldn't normally work together, create spaces for innovative work. So the point we want to make here on leadership is that it is really important, increasingly important, to understand what the work is, to be curious about the problem, and to make some judgments about what leadership practices are going to be productive, relevant to that problem. And I've seen many leaders and organizations derail because the wrong set of practices have been applied to the wrong question. So when you do have the classic problem, a sort of challenge, people like Cotter, this kind of methodology for change, which many of you will be familiar with. I'm not going to read out the slide, but it's a very kind of top-down, can be really effective for the right sort of problem. But if you are faced with these complex challenges, such as the one that I've given as an example, how do you get genetic science into practice? How do you get medical knowledge into practice? Then the argument we're going to make is that it's really important as a leader to think about context and understand the context and the culture and the subcultures, just in the way that I've outlined these different groups who were really different communities of practice within the genetics example that I gave. And so we need to be increasingly mindful of context before we start to try and think about these very challenging problems. What power do we have? What do we need to preserve in this change? One of the things that struck me over many years is that leaders get so excited about change that they forget to nurture and to preserve the things that work. And diversity, making the point again that these different subcultures exist. So we need to be mindful of that as well. So where am I ending? And I promise I will hand over now to John, is to think a bit about this role of leadership. And what we're arguing here is there are many different ways to lead as individuals. We will all have our strengths, important to really, really learn to love those strengths and to think a bit about the building teams to complement those strengths. But a crucial part of doing leadership work is to really understand the problem we are trying to solve. And if it's a technical challenge, you can see that the leadership work is almost more classical, motivation, measurement, setting the goals, vision, the Cotter type of approach. But when you are faced with these complicated problems, then, the notion of understanding the context, thinking about nudging the context, seeing leaders as architects, lots of analogies I can put up. My favorite one is leaders are a bit like farmers. Farmers don't grow crops, but they do create the conditions for crops to grow. So shaping the context through narrative work becomes important. And Heifetz talks about the importance of leaders increasingly getting on the balcony, by which he means find a place in the organization where you can see what's going on and really begin to understand and notice the patterns. What are the patterns that you can see in who's working with whom, who never works with whom? And he talks about this balcony dance floor metaphor, that we as leaders need to get on the dance floor to understand, but we need to look at the patterns from the balcony. And this more narrative description of the future that is giving meaning of work to people becomes important. And the humility that leaders need to have, I think, to increasingly to recognize that somebody there knows how to solve the problem better than you. So give the work back to the people who can help you. And this notion of conflict is not always a bad thing. It has to be a challenging, psychologically safe space that we need to create increasingly in our leadership work, so that we can have these debates on diversity in a kind of safe and productive way, and this notion of encouragement, coach, and challenge. So I think that is all I'm up for saying, John, but just making the point that change is complicated, everybody knows that, but we need to be more mindful about the kinds of leadership work that we need relative to the work that faces us. So John, those are just some thoughts from me.
Thank you very much, Sue. Yes, and it's a hard act to follow. That was a great presentation. I mean, some of the things you said resonate with me very strongly. Certainly, the change in leadership going hand in hand, healthcare being a very complex environment. I'll talk a little bit more about that. Just by way of introducing myself, I'm John Powell. I'm Professor of Digital Healthcare here in Oxford at the Nuffield Department of Primary Care. I'm also Academic Director of the new course in Global Healthcare Leadership, which is starting this autumn, which is an executive master's program where we're hoping to bring together the best of what the business school can offer together with the Oxford Medical Sciences, and hopefully more of the same sort of areas covered in that course. I mentioned complex system in healthcare, and I know probably everyone on this call is familiar with the usual comparison between what's complicated versus what's complex, and getting a rocket to the moon is complicated, but bringing up a child is complex is the usual metaphor people use. I do think health systems generally are very complex systems. So even when the problem is not a complex problem, it still becomes a complex problem when you're trying to implement it in healthcare. Your study of the genetic services, Sue, resonates very much with my experience in my career. So I'm a public health physician by training. I've worked in public health in the UK for over 20 years. I currently work for NICE, which is the National Institute for Health and Care Excellence in the UK, which is our main health technology assessment agency, HTA agency. And I work there on innovation, particularly innovation in surgery and getting new surgical procedures into practice. And that's a good place to observe the epistemic clashes, because you have all the surgical tribes around the table, but you also have the clashes between clinicians and the epistemic clashes between clinicians and academia and industry, all evident at committee meetings and in discussions. And I think we do wrangle with those epistemic clashes all the time in the practice of health policy and public health. My particular area is digital healthcare, is where I do most of my research, and so the connection with my NICE work is it's all about innovation. We're going to have two breakout discussions, which I'm going to introduce in a moment. The first of those discussions is going to be more about a leadership topic. The second is going to be more about a digital health topic and change in health services related to digital, which is my area. So I want to introduce those. I mean, being a public health physician, obviously the last year or so has been very interesting to observe. I haven't directly been involved in the COVID response, although I helped write some of the treatment guidelines for NICE for some of the guidance on COVID treatment. But everyone's, if you go on Twitter, you'll see that everyone's a public health expert these days anyway. So maybe they didn't need me, but I'm obviously joking aside. But what's interesting from a public health point of view is I think that I think the pandemic has demonstrated to everybody what a political enterprise public health is, and always has been, but it's just not been to the fore so much. That public health decisions are necessarily political decisions. So decision, and you'll be aware of debates around, if a country goes into lockdown, is that about protecting public health or is it damaging the economy? And actually, I mean, I would argue, as many people with my background would, that it's actually those are two sides of the same coin, that actually by protecting public health, you actually probably do the best for the economy at the same time. I appreciate that's a debate that we could get into at length here, but the general point that public health is a political activity, I think it is an important one to make, and that public health leadership, I think, has been to the fore in this pandemic, or certainly has been visible in this pandemic, for better or worse, depending which country you look at. And so the first of these breakout discussions, we wanted to think about how health leaders, and particularly thinking about public health, have dealt with uncertainty in this pandemic. And Sue mentioned the important skill of being able to deal with uncertainty that leaders face, that sort of swampy penumbra that they're faced with in their roles, and that uncertainty being one of the key challenges, alongside adaptability, etc. And so, like I said, the second breakout will be more around digital, but I'll just introduce the first breakout for now, reflecting on leadership during the last year or so, during the COVID pandemic. To what extent have leaders, whether that's of governments or organisations, demonstrated their ability to deal with uncertainty? And please, by all means, pick a specific example and drill down on that example and think about how they've coped with some of those questions around, in the early days, what is this virus? How's it going to behave? What measures should we take? When should we take those measures? Is it about maximum protection of public health, or is it about the economy, or is it about both, et cetera, et cetera? All those questions which you will be familiar with, but particularly with that leadership lens, and the ability to deal with uncertainty. So we'll put you into the breakout groups now. We will gather back in 15 minutes time, where we will have some reflections on that, and then we'll move into the second breakout. So I'd like to welcome everyone back from the breakout rooms. While you just have a moment to think about what you were just discussing, please do write in the chat. I think the groups each probably were given a number, so you were group 1, 2, 3, 4 up to 6. If you want to write in the chat some feedback, do, and I can pick up on that. If you want to volunteer to speak, then do raise a virtual hand. Otherwise, I might just pick on some group numbers. But I just, maybe the first question is whether, thinking about that question about uncertainty, is whether you had any particular reflections on that quality of leadership, that being able to deal with, when I see it in the evidence-based medicine world, and if you do look at the discussions on Twitter or elsewhere in evidence-based healthcare, you'll see this brought to the fore, that this, when you've got, what do you do when you've got no evidence? And there are disagreements within the evidence-based healthcare world, profound disagreements about that, around certain issues. I mean, Sue, I don't know if you wanted to thinking about your sort of hierarchy of problems, the sort of crisis management type problem and the tame problem, and like, in your own experience, but also what was said there in the early stages, that quick, decisive action and clear.
I think, unless you make a really important point about how problems can change, and maybe that was something that I didn't say enough of, that it's not as though things stand still. So it's this vigilance and understanding about what practices are needed to solve that problem that becomes so very, very important. And I think, we've never seen uncertainty like this. I think it's interesting to reflect on what we're noticing about good leadership practice in these circumstances going forward. But I think you made a great point, the people who have spoken already, about the nature of the problem not necessarily being static, that it can evolve and change and go backwards and forwards like that. So that's a great point.
Thank you. Someone chat has picked up on my observation about flu and MERS, SARS, and this was really just from me, from public health colleagues, hearing that certainly in the UK, what pandemic preparedness there was geared to the next pandemic likely to being influenza, and that perhaps some of the delays in that first lockdown, etc., that we experienced were based on assumptions that were more close to the influenza as a virus than a SARS virus. We wanted to have a second breakout discussion, same format, same ground rules, but different topic, because we looked at one area of leadership quality in that sort of swampy area, the uncertainty, and then the other thing we wanted to think about was change, and change in healthcare being difficult, as Sue discussed. And my area is digital healthcare, so how health services are increasingly turning to digital technologies to address some of the challenges that health services are facing in terms of reduced budget, increased demands, aging populations, people living longer with chronic diseases, etc. And that digital, particularly in the policy rhetoric, digital healthcare is held up as a response, as an answer to many of those challenges. That digital interventions, for example, can be very patient-centered, can support remote care, can be cheaper, scalable, greener indeed, because they reduce travel, etc. And of course, in other sectors other than healthcare, digital has been often heralded as a disruptive innovation that can really challenge the accepted models of delivery of business in other areas. And I just, for the second breakout, we were thinking just have a think about digital healthcare and digital transformation of services. But to what extent do you feel that digital technologies are disrupting the business of healthcare? To what extent are they achieving change in health systems? And the example I picked up there was direct to consumer apps. But if your group wants to choose a different example, then absolutely fine. But we were just thinking of the direct delivery of interventions to patients, potentially bypassing traditional health services. And so that was the topic. And again, we'll break you out into small groups. We'll reconvene, and then we'll pick up on some of the points that come from that. So welcome back, everyone. I think I'm just going to talk for a few seconds while everyone rejoins from the breakout rooms. It looks like the participant list is back to how it was. So thank you, and thank you for taking part in those discussions. We've just got a few minutes to reflect on the final breakout before we wrap up. And I guess where I was coming from in posing this question was that, like I said to you earlier, I work for NICE as well as do my academic work. And NICE is constantly told in many areas, but not least digital health, that the sort of robust, rigorous, credible processes that it uses in order to regulate and be an HTA agency are at the same time slow and not very responsive, and perhaps an inhibitor to innovation. And NICE constantly struggles to meet that challenge to try and promote innovation in a sufficiently agile way, but while at the same time maintaining a level of rigor that's useful to the health system and protects patients. And with the emergence of digital health technologies, that's been a new challenge for us, because that's actually been, even that argument is being pushed even harder, that NICE is being sort of anti-innovation. It's not really allowing these new modes of digital delivery of services to flourish and to challenge traditional modes of working, because we are expecting them to jump through the same old traditional hurdles of regulation. So I was just interested in to what extent you felt that digital tech is transforming health systems, whether that's in this country or in other countries. So I don't know if anyone wants to start. Otherwise, I might have to pick on people again. I'm looking in the chat channel if there's any comments made. I mean, certainly my own reflections in this country are that despite a lot of rhetoric and a policy enthusiasm for digital, I would argue it's not yet been disruptive. I don't think it has yet changed the model of delivery of healthcare in this country. I'm going to have to hand over to Sue to wrap up. So thank you, everyone.
Yeah, well, thank you very much indeed. That was really helpful. Thank you, John. And we're really encouraged by the turnout in these sessions. And obviously, if you want to follow up with anything that we've been talking about, we're both happy to do that.